I'm delighted to be able to welcome you to today's grand rounds, and also would like to take the opportunity to welcome our applicants who are online for what's going to be a very entertaining and computer-generated version of what some of Jake's ideas are. For those who don't know, Jake Peterson is a really wonderful person to work with, and as one of our senior fellows who joined us at the VA looking at different ways that we can use computer assistance to improve quality of care for patients in the ICU. Along those lines, he's been working with us on this Arts Quest project that's supported by BARDA and the VA, and is extremely well-trained for doing this. He also seems to continue to need to get more degrees. I'm hoping his MHS that he's currently enrolled in will be the last one, but he went through his undergrad and med school training at UConn and then served in the Navy, and has just always had a wealth of really insightful experiences to share, and is a tremendous speaker and thinker. So I want to welcome to the podium.
Thank you for the introduction. Yeah, a lot of weird experiences, which I think will become apparent as we go through this journey together today. Thanks for coming, everyone. Thank you to the applicants for joining us today. Hopefully your mornings went pretty smoothly. You got a good sense of this place and its people. My research focus, as Dr. Atkin mentioned, has been with the Arts Quest team working in the area of clinical informatics on ARDS identification and monitoring and treatment at the VA. And so I thought it would be fun for me, and hopefully for you guys too, if we talked about how we came to generate these data that we use in our clinical practice, and how our practice of medicine has evolved along with these data through time. I have nothing to disclose. My interests are not conflicted. And so show of hands, who recognizes this movie? Okay, most people, good. Because if you didn't, it's going to be like a long talk for you. It's going to be featured pretty heavily today. I like the movie Willy Wonka and the Chocolate Factory, and you gave me the podium, and it's too late now. So we're going to talk about it a lot. If you don't know what it is, for like maybe one or two people, it's basically a film where a group of children win a tour of a working candy factory, and under pretty minimal supervision have pretty serious disfiguring workplace accidents one by one. More specifically, we're going to focus on this little tyke, Mike TV. Anyone remember what happens to him, what his deal is? No? So he discovers that Willy Wonka, the chocolatier, has somehow developed an experimental technology to transmit chocolate bars via television through a camera, transmitting them wirelessly and then downloading them on a screen. He's so excited by this that he immediately hijacks the experimental technology, vaporizes himself, and sends himself across the room. And so his little journey across that room is going to be our roadmap for today. And it has three main elements: the camera that converts him into data, him as data going across the room, and then him being reassembled on a screen on the other end. And so we're going to start with talking about how we built the camera. In this case, in our analogy, it's how we developed the ability to even measure our patients and assign numerical values to the aspects of their health. Second, we're going to talk about what happens once we've transformed the patient into data, or the boy, about the modern ICU, how it was developed, the amount of data we generate, and try and understand some of the challenges we have in interacting with it and using it for patient care. And then last, we're going to talk about how we try and take the data we make and translate them back into something that is more coherent and usable as we try and assess and treat disease, particularly in the ICU. We're going to talk a little bit about the work we're doing with the VA, with the Arts Quest team, to improve ARDS care and identification. So we'll start with how we developed our ability to even measure human health and how our practice of medicine has evolved along with those tools. We're going to start right back at the beginning of medicine. So modern medicine, founded with Hippocrates around 400 BC, who promoted the idea that human health had rational and natural explanations. Because at the time, most of our understanding of health had to do with superstition and divinity. And he really was the first one to get us away from trying to explain disease by how a deity felt about you. He practiced the humoral theory of health, which involved maintaining the balance of various biles and phlegms in the body, and focused primarily on observation with the goal of providing prognostic information to patients. Around 500 years later, Galen came along and added a lot more structure to this way of thinking. He tried to explain how organ systems worked in more detail, provide more treatment options, and expand this method of thinking. This system of medicine relied heavily on anamnesis, which is the recounted history, and diagnostic testing was pretty much non-existent by today's standards. Evaluation was totally limited to what you could sense with your eyes, ears, mouth, nose, and tongue, unaided. And so our practice was much more art than science. An example that I'm sure we've all heard of is tasting urine to diagnose disease, or spilling it on the ground and seeing if bugs were attracted to it. People felt that this would give them valuable information about the humoral state of the patient. And this practice, as well as like the general approach to disease and medical treatment, persisted well into the 18th and 19th centuries. As you can see in this article from just over a year ago, the question of drinking urine for health benefits still has not been conclusively put to bed. And so the first major pioneer to change this was an Italian doctor named Santorio Santorio, who had been Sanctorius in around 1600. He developed the first precision instrument in medicine, which is pictured here. And I think we all know what this is and what it does. For maybe the one or two people that don't, it's a pendulum with an adjustable length cord called a posologium. And so what he would do is adjust the length of the cord and thereby the period of the pendulum swing until it's synchronized with the patient's pulse, and then record the length of the string as a surrogate for pulse rate. He's also credited with inventing the first thermometer for oral use, adapting design from Galileo. And these discoveries marked the first time that we had information about a patient that we could compare both between different patients objectively and in the same patient over time. Does anyone know what he's doing here? Anyone like hazard a guess? No? Julio? It's not a PFT. A very well-fed PFT. But points to you for like venturing a guess, even though yeah, it's not a bad guess. So he ate, slept, worked, and excreted on a large scale for like 30 years. And this allowed him to posit for the first time that the amount he was able to measure coming into him was more than the amount he was able to measure coming out, and formed the first description of insensible losses in basal metabolism in human health. And so now you know that forever. The concept of physiological measurement was a huge shift in how we were able to think about disease, but adoption was pretty slow and almost non-existent for the next 200 to 300 years after him. To illustrate just how slowly these measurement technologies were developed and how slowly they were to be adopted, we'll look at the measurement of blood pressure as kind of an illustrative example. The first real attempt to measure blood pressure was by Sir Reverend Stephen Hales, or Reverend Stephen Hales, I don't know if he had it in 1733, who would attach a copper tube to various arteries of a horse to a large glass manometer via a goose trachea and measure how high up the blood came. In this case, in the carotid artery, it was like 8 feet 3 inches. And in doing so, was the first person to demonstrate that blood in a vessel is under pressure and to quantify that amount of pressure. And it was the father of modern hemodynamics because of that, or hemodynamics. He was British. If you're curious, the horses, there were 3 of them as well as a deer, were not explicitly noted to have died from these experiments. However, he does note that the amount of blood in the glass manometer seemed to get less the more blood he let out of the horse. And so I choose to believe that the horses were okay. It's harder to convince myself that the goose was okay. So anyway, blood pressure measurement technology really had no movement until about 100 years later, when someone adopted this design to be a mercury-filled manometer. And then 70 years after that, until we had the sphygmometer, which only do systolic blood pressure, until around 10 years after that, you had crocodile sounds, and you could use diastolic blood pressure as well. And it wasn't until 1929, a full 200 years after Stephen Hales, that we had invasive blood pressure monitoring in people, which was actually a German resident at the time named Forstmann, was playing around and put a catheter into his arm until he figured it was somewhere in his heart, walked down to radiology and got a chest x-ray done to try and confirm placement. And the German community was like very unamused by this. And they banished him to urology, which is the terminology used to describe this, which doesn't entirely make sense. But he did get a Nobel Prize in 1950s for it. And so this timeline of like very intermittent developments in technology and like really accelerating at the end of the 1800s is pretty typical for things like pulse measurement, temperature measurement, understanding like fever curves. And it wasn't until like the early 1900s they had EKGs and like clinical laboratories. And so as our measurement tools became more ubiquitous and our understanding of health and human disease changed, the setting of diagnosis for the first time moved away from being an obligate bedside activity. And so there's actually an interesting article from Abraham Verghese, and these titles are from his paper looking at the shift in the way we thought about diagnosis by the way that medical textbook titles changed around this time. And so before the turn of the century, medical diagnosis, clinical diagnosis, bedside, physical exam were all synonymous terms. You didn't have to specify that you were diagnosing physically or at bedside because that's how diagnosis was done. But then you start noticing in the early 1900s that you have to start thinking about physical diagnosis, bedside exam, physical exam, bedside exam, because now diagnosis is not something that is done exclusively at the bedside. All of these advancements set the stage for the birth of our specialty. So in 1952, there was a polio epidemic in Copenhagen. Bleghem Hospital was kind of the epicenter of this, and they were admitting 30 to 50 people a day at a time when polio with bulbar involvement carried upwards of a 90% mortality rate. The standard for ventilation of the day was negative pressure ventilations with things like the iron lung or the Curis ventilator, and the hospital only had about 5 of these. And so in conjunction with an anesthesiologist from a nearby hospital named Bjorn Isben, they pioneered the use of large-scale tracheostomy and positive pressure ventilation with bag valve mask, which allowed them to ventilate up to 70 patients at a time, powered by an army of medical students working the bag 24/7, paid £1.50 per shift. In doing this, they're able to take care of everybody they needed to, and they also reduced mortality from that 90% to 40%. And so Bjorn Isben, seeing this, attributed a lot of the success to the individual attention that each patient was getting. And so conceived an idea of a ward where there was a 1-to-1 patient-to-nurse ratio. In December of 1953, the first ICU was born. Also worth noting as an aside, the use of blood gas analysis was instrumental to this success as well in identifying and preventing hypercapnia. It was actually based on technology invented by Dutch beer scientists who were trying to make smooth beer and invented the technology to measure pH. And so our understanding of ventilatory practices at the time was like pretty crude, I think we'll agree. And we're going to circle back a little bit later to how we're doing now when we talk about ARDS. Also worth noting, in the 1950s, the first computers were being developed into commercial products. Adoption in healthcare is really just for financial uses to start with, but eventually individual hospitals started making their own medical records, which were rarely linked to real-time clinical data. It really wasn't until 1966 where Shubin and Weil brought in a computer system to the ICU that we had like real-time data. So this is a schematic of their system and an IBM 1710. And what it would do is collect venous pressures, arterial pressures, urine output, pulse, pressure, process them in one of these machines, and then provide the clinicians with like a rudimentary trend analysis and charts. These systems continue to evolve over time as commercial products such as Patient Data Management System by HP came into more practice. And adoption in the ICU was shown to reduce length of stay, improve documentation time and quality, and eventually evolved into these large enterprise systems that we know today by the 90s that could incorporate vast amounts of data from your labs, your imaging, clinical documentation, vital signs, signal analysis, and deliver them to the clinician, as well as some rudimentary like decision support that's been evolving over time as well. And so with the use of this technology, real-time assessment of the patient was enabled to take place away from the bedside totally for the first time in the 1970s when central monitoring stations were born. So not only were we able to make the diagnosis away from bedside, we could check in our patients without having to go and like actually see them. Our sensors, our lab assays, our medical record systems and computer systems have all continued to evolve since then to now we have the modern ICU where just about everything in this room except the commode and the bedside table has a battery and a Wi-Fi connection. And it hasn't stopped there. In 1977, the first instance of remote ICU care was reported when a university intensivist rounded daily via T-Way AV link with a smaller hospital. Over the next 20 years, communication technology became cheaper and more ubiquitous, and some data suggested that these systems could reduce ICU mortality and length of stay. And now these are really, really common, with up to 15% of ICU beds having some form of tele-ICU coverage as of 2018, and likely higher now. Here we see our very own Dr. Signer in our tele-ICU. And so with the advent and popularity of the tele-ICU, we've completed this journey from being a specialty that was obligatorily at bedside, using our senses unaided, to being a profession where you may never, ever be in the same room as the patient you're treating. It may never actually use your senses directly to assess them. And so with that, I think we've covered some of the wave tops of how we got to our modern ICU and how we developed the tools to quantify our patients and turn them into data. Next, we're going to talk about the data themselves and how the pieces of Mike TV fly over our heads and some of the implications for us as care providers. We've come a long way from the pulsologium and goose tracheas. And now in the modern ICU, we routinely track in the order of hundreds of variables for patients with thousands of data points daily per patient on average between things like vital signs, lab data, radiology data, signals data, and clinical documentation. This chart is actually from 2008 and one of the first studies to look at the volume of data that we deal with in the ICU, in a pediatric ICU, and they found that on average around 1,400 data points were being generated per day. And a lot of these data are literally and figuratively noise that we have to navigate. Our equipment can make more than 700 alarms per day per patient, 65 to 95% of which can be false alarms. And so not only is the volume of data itself kind of staggering, but also a lot of the real data can be buried in the literal and figurative noise of our machines and false alarms, extraneous data, inaccurate data. We see here, for example, this is reports of alarm frequency in a 21-room ICU over the course of a typical day. They have a ventilator alarm going off about once a minute on average, and EKG and blood pressure alarms about half as frequently. Outside of the data we generate with our machines and sensors, clinical documentation is also an area where we suffer from data overload. We bury important information in our notes in a sea of auto-generated and copy-forwarded trash, with as much as 71% of the note being templated or copied as of 2018, as our notes serve these dual purposes of communicating our thoughts and assessments and plans, but also justifying billing. And that 71% figure is likely an underestimate now, as that was from 2018. And as you can see here, both note redundancy, the proportion of notes that was from auto-generated or copied text, and note length had been steadily increasing leading up to that point. With this trend, trying to find valuable data in our patients' records is more and more of a scavenger hunt that occupies more and more of our time and is less and less successful. And as our environment gets more complex, our work habits have been changing as well. More and more, we're facing, instead of continued concentration on a single patient or problem, a series of short, randomly injected tasks throughout our day, which prevents us from really concentrating. We see here the results from a 6-week observational study on a typical ICU rounds, looking at the total number per rounding day of interruptions between things like alerts, pages, alarms, people having side conversations, asking questions, and trips to EHR to verify or acquire data. And they found that interruptions do have a positive correlation with people making mistakes on rounds, particularly technological interruptions. Additionally, the rate at which our medical literature is coming out is increasing. In the 1950s, the doubling time for the body of medical literature was somewhere around every 50 years. Now it's probably closer to every 10 to 15, although there's a really aggressive estimate out there that puts it every 70 days. And there's a distinction to be made between what is published and what is clinically relevant. But the point remains that the speed at which our data are coming in terms of our clinical knowledge of disease is increasing, and staying up to date it can be challenging. It's probably going to get more challenging as time goes on. And because of all of these things, the amount of data and the difficulty involved in deciphering them, the EHR increasingly dominates our time, leading to less time that we spend at the bedside. One study actually tracked physicians throughout their day in the ICU with wearable trackers, and found they spend on average about 15% of their time in patient rooms. The rest is spent at computers, which I think tracks with how we perceive our own days. One paper, though, suggested this is actually probably a good thing, because if we spend less time with our patients, we're less likely to give them communicable diseases from other patients. But for better or worse, we're spending less time with our patients and more time with our computers as we wade through all this sludge of data and notes, so that we ourselves can turn around and create more for the next person to wade through. And of course, there's benefits to our golden age. No longer is legibility an issue. Communication is faster, more reliable. You don't have to track down paper charts. Data can't be lost. Results are available pretty much instantly and transparent to patients. In general, we as providers feel that we have a better overall situational awareness of what's going on compared to before computerized systems and this amount of data. But there's also costs to the system we have. Our brains are not equipped to process this amount of data, and the ICU is commonly a place of cognitive overload. The sheer amount of data, as we've seen, is pretty incredible and only growing as time goes on, and that impacts both our patient safety and our well-being as providers. You take a breath. That was the weirdest one. We made it through that one. All right. From what we know of cognition, our brains can only handle about 3 to 4 items of visual memory, short-term attentional focus at a time, and we can only really focus on one task at a time. Because of this, most decisions we make are really only based on 3 to 4 points of data. The really skilled among us, maybe 5 or 6, but we often overestimate how much complexity we're incorporating into our own decisions. As we try and incorporate more data or have our attention split by competing interruptions, alerts, what have you, our cognitive performance declines pretty rapidly. Once we're in a state of informational overload, as we frequently are in the ICU, adding more data can actually have a paradoxical effect of further degrading certainty and decision-making. And I think we're aware of that as we travel through our day, that like more data often makes things harder, not easier when you're trying to like complete a task. In a survey of primary care physicians, as many as 70% said that they had more data than they felt they could deal with on a regular basis. And 30% said that they felt they missed important results that delayed patient care. And our environment's different from primary care. Our data come at us faster and there's more of it. Our patients are sicker and decisions are needed sooner. And so because of all these things, information overload is consistently cited as a factor in physician stress and burnout. Our brains struggle as we continue to try and work beyond our physiological limits in a way that we can't surmount with increased effort or training, that we're just not capable of doing the things we're asking our brains to do. One manifestation of that is that we have pretty significant variability in the way we practice, both as within our professional community and as medicine as a whole. Medical error continues to be a major issue, with one report saying that it's the 3rd leading cause of death in the US. And while you can certainly debate that figure in particular, a more recent figure puts the average number of Americans who are killed or disabled annually somewhere around 800,000 from medical misdiagnosis alone. And so we don't synthesize data reliably or consistently, and even where proven treatments exist, we don't implement them reliably. A familiar example is ARDS care, where the LungSafe team back in 2016 demonstrated that between 20 and 50% of ARDS cases were missed by clinicians on their reviews. And they saw as well here, you can see here, that the application of lung protective ventilation was around 66% in the people they saw. Fast forward to 2024, and the graph looks pretty much identical 8 years later. We're still not diagnosing this reliably. And we saw that in our VA population, the ArdsQuest team, where roughly 50% of the cases we were able to identify retrospectively using our methods were missed by the clinicians that were treating them. And we can't blame our under-recognition or under-treatment of ARDS on it being like a super complex diagnosis that requires niche expertise and specialty testing at tertiary quaternary centers. The treatment for it is not controversial, this treatment in particular, and requires just changing numbers on equipment that's already in the patient room. And so the issue seems to be more with how we receive, synthesize, and act or fail to act on the data in front of us. I think it's a pretty clear example of unreliable decision-making in the ICU. And so hopefully now you're on board with the fact that our current system, while the best we have, has some problems that we are working on overcoming. And so we're going to talk about how we try and do that and take all this data that can be so overwhelming and impair our decision-making and turn into something that we can use reliably to assess and treat our patients. The most common approach to doing this is the type of intervention called clinical decision support, or CDS. CDS tools are software functions primarily that are designed to improve quality of care, usually through assisting the clinician with putting this data together and making consistent decisions. They can take a lot of different forms. I think the ones we're most familiar with are pop-up alerts, but things like order sets, note templates, computerized order entry, links to guidelines and pathways, or even the way data are displayed like this anesthesia screen are all forms of CDS. There's a lot of challenges involved in development of these tools, both in just like getting the data together and in translating that to physician behavior changes and outcome changes. And we're going to talk through what's been done with ARDS in the ICU specifically and with our team at the VA as an example. For ARDS, efforts to date have primarily focused on improving low tidal volume ventilation. As we've just seen, is an area where we fall short pretty consistently. They've included things like standardized order sets, prompts when setting vent settings, clinical data displays, automated ventilation algorithms, and interruptive alerts. And in general, they have been modestly successful in improving tidal volume and driving pressure, but few of these studies look as far as patient outcomes. They mostly focus on changes in the behavior of the target clinician population. In one of these ARDS studies, they actually showed in their post-intervention group or their intervention group a 7% increase in 28-day mortality. And there may be something to that about the population changing over time, like respiratory viral season kind of hitting. But it does show, and we've seen this in previous grand rounds while working on improving AKI care, that there can be off-target effects from these interventions. And just because you change clinician behavior doesn't guarantee that you're improving patient outcomes. The two things are not inherently linked. And so we're going to talk a little bit about what our group is doing at the VA to illustrate how these systems are built. ARDS-Quest, the ARDS Quantification and Evaluation System, this is not the official logo of it for any of the ARDS-Quest people who are watching. It's sponsored through the VA Cooperative Studies Program, CSP, and BARDA, the Biomedical Advanced Research and Development Authority. The mission of developing a system to identify ARDS in real time or quasi-real time across the national VA system with two main endpoints in mind. And so one is improving the gaps in ARDS care that we've talked about through clinical decision support tools and trying to bring this information to bedside in real time. And the other is on providing a way of monitoring the nation for public health hotspots for respiratory disease so that we can better informedly respond to these types of events. There's three main lines of effort that are involved in making this happen. First is clinical data collection and analysis, which is mostly what we're doing here at the VA, and we're going to dig into this a little bit deeper. The second is development of a system to both import and then analyze the chest X-ray images themselves using machine learning techniques. And the last is how are we going to put the outputs of these other two arms together into something that can be delivered to the clinician and to the public health authorities in a way that's usable in form of like dashboards and clinical decision support tools. There's a lot of complexity to how these systems are designed and built. And so we're going to talk through our piece of it here at West Haven to illustrate some of the issues just in going to the chart to get things like vital signs, ventilation and support data, chest X-ray interpretations, and incorporate them to the larger project. In general, data can come in two flavors, structured and unstructured. To say data are structured is to say they have some kind of reliably predefined format, such as integers, dates, categorical values. And so if you know the database you're looking for and where this data exists in the tables, you can relatively reliably query the table for, say, a glucose value and know what you're going to get back. You're going to get back an integer number. And so this would be an example of structured data. This seems like pretty straightforward. And as far as like data acquisition goes, it is. But just because you know what you're going to get in terms of format doesn't mean the data are going to be there for the patient you're looking for, the time frame you're looking for, and doesn't mean that they're going to be accurate. And so we've seen that in some of our initial analysis pulling PaO2s, FiO2s, and trying to do P to F ratios, getting some like ranges from single digit P to F ratios to like in the thousands from things like typos and whatever. And so you have to still clean the data and try and figure out like what was even plausible, what makes sense. The other type of data are unstructured, which can be a little bit more challenging. When data aren't structured, we're generally talking about free text entries where there's no predefined format or formatting. And so you still have the same issues with missingness of data, but you also now introduce the issues of the location of the data can be different depending on what you're trying to find. So like, for example, we're looking for respiratory support values for our patients at the VA, and those are most reliably found in respiratory therapist notes, but they could be also in clinician notes. And depending on what time those are entered, you may not get values for the exact time you want. And so there's lots of issues with potentially typos, with formatting changes. And as you see here, these are 4 different RT notes or excerpts from RT notes from the same patient from the same 24-hour period. And the way their vent settings are recorded, this is the first patient I looked at, by the way, for this. I didn't like have to hunt for this. Wildly different for each of them. And so you might be able to appreciate like trying to train a computer to reliably find the tidal volume or the PEEP or the FiO2 can be challenging, and it has been. Beyond extracting numbers from the medical record, we're also looking to extract concepts such as, are bilateral opacities present that could represent ARDS? And that's been what most of my effort has been on. Our initial approach, which we presented at ATS this last year, involved searching for a year's worth of ICU patients who had ICD codes indicating acute respiratory distress, respiratory failure, and then looking through all their chest X-ray reports to see if the reports contained a term that indicated bilaterality and a term that indicated opacity. And this worked in that we were able to identify a cohort of patients that was enriched for likely ARDS cases, but it was really non-specific. And so this approach doesn't take into account things like negation. So if opacity was mentioned to not be present, there's no opacity. This doesn't detect that. And it doesn't know syntax or grammar in the sentence, and so it doesn't know that we're saying there is opacity, another sense saying there's bilateral effusion. That would still trigger this, despite not being what we're looking for. It also doesn't know which parts of the report are from the person who actually put their eyeballs on the film, which is what we want, or things that are like what the ordering physician thought they might see on it, or templated text, and that can cause some issues too. And so separate from the main ARDS Quest project, I've been doing a master's degree in clinical informatics and data science. Thank you to the section, by the way, for that. And chewing on this problem as a way to try and learn more about natural language processing, NLP, and how to turn these unstructured data into something that's more structured. And so the program I use, which we'll talk through a little bit, use a more nuanced approach, and it's called Chest X-ray Labeler 9001 TM. And you do have to say the TM after. Here's an example of how it functions. And so it's fed a report once everything but the actual findings and impression has been stripped off of it, and breaks it down to individual sentences. The words are simplified in a process called lemmatization, which removes tense and plurality to make it a more standardized set of terms that we're going to be working with. And then it searches each sentence for see if any terms of interest are there. And so, for example, in this sentence 1, ET tube is a term of interest, indicates the patient is intubated. And then it looks to see if that is negated, if the ET tube is mentioned to be removed or not present or no longer present, or if it's mentioned to be on the left or the right. And so for this patient, the ET tube is present. It's not having any laterality, and so it's scored 1. Things that are not present in the sentence, not mentioned, like the sentence that says nothing about cardiomegaly or effusion, are scored a 0. It's agnostic about those findings. And then things that are meant to be normal or are negated, like the effusion, there's no effusion pneumothorax, the cardiosinus silhouette is unremarkable or normal, are scored a -1. They're specifically mentioned to be absent. For left and right, it will score left and right separately, and if there's something on the left and the right, then by definition it must be bilateral, and so we'll score that as well. And so it takes these scores on a per sentence basis and then aggregates them into a set of standardized, now structured labels for the report as a whole. And so for us in particular, we're interested in this bilateral consolidation tag because this could be ARDS. So we want to know reports that could be ARDS. This allows us to process a lot of reports pretty quickly, and can also be used as a jumping point with which to train a neural network-based classifier that's a little more sophisticated, or to provide rough labels for the machine learning team working on the chest X-ray images themselves to provide some initial data for their algorithm about what things the machine might anticipate seeing on that film. More recently, I've been doing work with a clinical data extraction tool developed here at Yale by Dr. Zhu and his team called Kiwi that follows a similar approach to what I've done and just showed you with the chest X-ray labeler 9001 TM. But it is more robust in that it was done by people who do this for a living and know what they're doing. And so this excerpt shows an example of how it works. It searches the text for problems. In this case, it's found a hazy opacity, it's found pneumonia, and it's found diffusion. And then a search for things that modify those problems. And so in this case, the problem of hazy opacity has found to have the attribute of a location, the left lung. The finding of pneumonia has the attribute of being uncertain, could be, in the case this might not be certain. And effusion is noted to be absent, it's negated. And so this program returns a document that has all these relationships codified, and then using a similar approach to that I'm doing in the chest X-ray labeler 9001 TM, I can extract a list of labels for the report as a whole. But as we've just seen, so, this has all just been about data like collection and pre-processing, and this has occupied like a year and a half at this point. These are not easy things to do. And so once we overcome these hurdles and we're pretty close to having like a working prototype to use, we still have to decide what we're going to do with this data. And so designing the dashboard to inform the public health efforts, as well as the clinical decision tool that's going to alert clinicians. Where is that going to go? Who is it going to alert? When is it going to fire? Can they ignore it or not? And this is all balanced against trying to not make worse the problems that we see with physician cognitive overload and attention splitting. And so we'll have to, once we have it in practice, the clinical decision support tool also have ways to monitor our clinicians actually recognizing ARDS more. Are they treating it more? Is it changing meaningful patient outcomes? And likely continue to refine the intervention as like an ongoing quality improvement type project to make sure it's working the way it needs to. But even if we do all of these things really well, it's worth noting that clinical decision support tools have not been a panacea to this type of problem in general. The effects of these interventions are generally pretty modest, with increases in desired behavior somewhere in like the 4 to 7% range, and data on CDS tools impacting mortality generally more limited. There's a lot of reasons for this. We talk about alerts firing at the wrong time for the wrong person, or just being too sensitive and firing too often. One report looking at prescribing alerts found that 90% of the alerts were bypassed and 80% of those were appropriately bypassed by clinicians, which again, I think kind of tracks with like our experience. Like we bypass a lot of these alerts. Worth mentioning too, that even when these tools are working really well, most institutions have a pretty bespoke data structure to the way their EHRs are set up, to the point where if we find something works really well for us here at Yale, say, that doesn't mean we can just plop it into Hartford's Epic if we were so inclined to do so. There's a lot of work that has to be done on finding the correct pieces of data and where they actually live in the different systems. And so it's hard to generalize these things. And so in our current system, I think, maybe initially we envision ourselves the people sitting at the computer, looking at the data that's now been put back together. And I think there's truth that we certainly are like more and more facing our computer with our backs to the actual physical patient. I think in reality, we really haven't even gotten this far as putting the patient back together as some kind of coherent picture on the screen. I think this is probably a more accurate analogy to how we practice medicine in the ICU right now, where we're looking at all the data, doing our best to make sense of it, and trying our best at like these very challenging tasks of seeing all the data, interpreting it all reliably and consistently, and applying the most up-to-date care principles to the patient in front of us reliably. And our attempts at CDS so far have largely just been stopgaps to try and make sure we don't miss critical details in this system. And so in this analogy, you might have an alert that says like, hey, this dot's a toe. People are missing toes way too often. We need to make sure people aren't missing the toe. This one's Mike TV's ear. We want to make sure people aren't missing that one. But we're still largely left trying to sift through the data ourselves and find it between all these different screens and formats. And so as progress marches on, the data stream has only continued to get bigger, and our meat brains have continued to stay the same size. And so no matter how brilliant the clinician is, things get missed. We see that in our healthcare quality assessments, and that we haven't made the progress we had hoped in improving healthcare quality over the last few decades. And I believe a big part of this is we haven't really adapted to the system we have as fully as we need to eventually. There's no amount of training or pop-up alerts that's going to be able to like get us over this hurdle. And so we'll talk about kind of where I think things maybe are going or should go. There's a reason we went through the medical history at the beginning of this. The main one being it gave me an excuse to shoehorn that like goose trachea horse story into the talk, because I think it's pretty cool. The second reason is it provides a little bit of context about how much our medical practice has changed over time, particularly just in these last 50 years with computers in the ICU. And so we'll back up and use another analogy to try and conceptualize this problem a little bit. What if this is what the inside of a typical airliner cockpit looked like, where thousands of data points, alerts going off every minute or two, people popping into the cockpit to ask questions frequently, families of the passengers calling, asking for updates. And what if in this scenario, these pilots, human and otherwise, crash planes all the time, to the point where 800,000 Americans per year were either killed or disabled. I think we'd agree this is like not a great system. We like would be pretty unhappy about this. And so what if somebody seeing the system said, you know what the solution is here? We need some more alerts. We need alerts for each mountain they might hit. We need alerts if they're too low, too high. And I think like common sense wise, we would agree that those alerts might improve performance with hitting those individual mountains. But I think 0% of us would be surprised if those failed to make flying safer as a whole, right? And so I bring this up, obviously aviation and healthcare are a little bit different beasts, but they share the similarities of being very high risk endeavors. And they are dissimilar in that the aviation industry has figured out reliability and safety, and we have not. And so what can we maybe glean from them and their approach that might help us in trying to solve this problem? One of the big concepts they use when they design their user interfaces or their cockpits is something called the quiet dark, where instead of piling on more data and alerts, they actively strip it away from the pilots. And so they're only alerted by things when they are actively abnormal. And so they can concentrate on the task at hand and make decisions more consistently. And so I think maybe a reasonable first step for us would be to use some of the tools that already exist to maybe offload a lot of the data scavenger hunt in the chart to an AI tool that could be trained to scour the record and give you a summary of the things that you might consistently be interested in as, say, a pulmonologist, in a way that would be much more thorough than we ever have time to be, and also free us up to spend more time with our patients. I think ultimately we're heading towards a future where we like truly try and reassemble the boy back on the TV screen before we interact with the data, which is to say, instead of trying to have these stopgap measures that call attention to individual pieces of data, we have a chart that is one unified clinical support tool that gives us the completely digested information all at once in one screen. And that we delegate a lot of the cognitive work that we're doing now, and that abuts the limits of our physiology to the computer. With time, these systems can provide more tailored treatment recommendations as we leverage the amount of data that we have in these systems to provide like very specific recommendations to patients. It also has the ability to potentially create an actual standard of care that is not based on clinician gestalt training or state of mind of the treating clinician, but more focused in data, and to also improve health disparities when expert clinician review of the same quality and caliber is not location dependent. And of course, there's a lot of hurdles involved in doing this, technical and ethical. We've already talked about how difficult it is just to get data together to diagnose ARDS. This is like obviously several more steps beyond that. These systems, when trained, are usually black boxes, and that we don't know how we can't with words explain how they got these variables and arrived at this result, yet we would still be responsible for acting on their advice, and our patients would still benefit or suffer the consequences of acting on that advice. And these systems, as they stand now, that are black boxes, they can hallucinate in ways that if you don't know what you're doing, you might not catch it. So like once you have hypovolemia here is a good one, levofed at a rate of 0. And there's a lot of bias baked into these models. One thing that actually came up today is in the original version of this talk, a lot of these AI generated figures were all white men. And so noticed that and fixed it, but that is like racial biases, gender biases exist in these systems in ways that we can't fully explain and might bleed over into our practice of medicine. There's also a concern about, as we offload the tasks of interpreting the data, will we as clinicians have that skill in ourselves atrophy, or will clinicians who are coming into the profession never develop those skills? And I think that's a very real concern. Although you could also make the argument that if patient outcomes are still doing well, then it might not matter. The only real like casualty of that might be our egos. And an example of that might be like, we don't taste urine anymore, right? Our patients still do well. We gave up that skill. Not many of us dial rotary phones anymore. People still make phone calls just fine. You know, the march of human technology has consistently meant leaving old skills behind as they become obsolete. And maybe this is just another extension of that as our role evolves along with our technology as it has before. And so I think in a system like this, we would be enabled to return to a focus on the humanity of our profession. We'd offload wading through that note sludge, that data sludge to a computer system, and we'd be responsible for understanding the physiology behind the recommendations and being able to maybe verify them. But much more, we would act as mediators between the analysis and the patient in front of us and their specific context, their values, their situations, spend much more time at the bedside. We could escape the world of cognitive overload that we live in right now and have happier lives, and our patients can be healthier as well. And so in summary, our ability to quantify human health has grown pretty rapidly, especially in the last 50 or so years, to the point where it now outstrips our brain's ability to deal with the amount of data that we make. Our current tools are very difficult to make to address this. They don't work particularly well, depending on your definition, and they can be really hard to generalize when you make something that works well. And so because of this, I think we are inevitably heading towards a place where we fundamentally change the way we interact with these data. And if you have a goose trachea on hand and don't mind your horse dying, you can transduce its blood pressure. I'd like to thank primarily Dr. Atkin for her wonderful mentorship in general, particularly with this talk, spending like a phenomenal amount of time with me, making sure it's great. And notably, not giving me any pushback on some of the weirder pictures, which I was really braced for. Our Arts Quest team as a whole, only a few of whom are here in alphabetical order. And then, of course, my family, my wife, Becca, and our two daughters, Stella and Sadie. If you're interested, you can try out the chest X-ray labeler 9001 demo here. There's some sample text uploaded and you can see how it works. If you want to see my references and make sure I didn't just lie to you for an hour, you can do that. And it'll be open for questions. I do have my notary stamps with me.
Great. Thanks so much, Jake. It's always really entertaining to work with you. And we at least adjusted delivery for some of the figures. So I would like to open it up to the floor. And for those online that have questions, feel free to enter it in the chat. Dr. Siegel.
Jake, that was fantastic. So provocative and really helping us all see the future, I think. I want to go back to the points that you made about information overload, particularly related to the huge amount of data. And I think that one of the things that I've often thought is that we're almost creating our own problem, and that some of the solutions aren't necessarily that high tech or don't necessarily have to be that far off into the future. And I'll give you a couple of examples. Like in Epic, when you get a CBC, you get all this irrelevant data like the MCHC and things like that that just cloud your visual field. Or when you get a blood gas, like I think experienced physicians can interpret it instantly, but I work with a lot of interns where it would be kind of helpful to have some help, like an interpretation. But probably one of the most important ones that I think about is that occurred to me when we started doing the tele-ICU was that the tele-ICU is able to, if I understand correctly, pick up on trends and set off alarms for trends that weren't available at the bedside. So for example, a patient's systolic blood pressure going from 140 to 100, or their heart rate going from 95 to 65 wouldn't necessarily set off alarms. But if you could see that somebody's becoming bradycardic or their blood pressure is dropping, you could intervene, but it's not visible the way we set up the data. So are those things not fixable in the short run in terms of how we're actually giving clinicians data that they should pay attention to?
Yeah, I mean, there was a study I saw but didn't talk about here that estimated the amount of data we actually interact with in the chart at like at most 30% of what's in there. And so to your point, like there is a ton of noise or things that we like don't find valuable in the chart. And that we maybe like the quiet dark kind of analogy of like trying to like figure out what do we actually need and like take away the rest. The trend analysis I think would be phenomenal, like a way to set off an alert when an alert needs to be set off. But still, like, I mean, I can't speak to how it works in the tele-ICU, but imagine there's similar challenges to the rest of clinical support tools in terms of like, how sensitive is it for specific, and is it triggering at times where it just becomes noise? But I think that's where we need to go, is like have some pre-digestion of these data before we interact with them.
Thank you. That's a great talk. And I think a really good preview of the places we're going, not just the place, because I think we don't actually know how this is going to shake out. But I think your observations are right on. The question is, I think there's more than one way to get there. I think most people here know, but for those who are listening in who don't know Yale, we rolled out eCart, which was essentially an AI machine learning tool that's predictive of cardiac arrests over the next 24 hours when the score is elevated. You know, as with a lot of these things, there was a bit of doubt, but we did exactly what you had referenced, which is that it had been used elsewhere, and we've had two other tools here which were not helpful. We actually ran the data here before it was adopted, but we were lucky to have a collaborator who could really do that, and that's not so easy to do. But it does what Mark's talking about, which is it's looking at all these variables, and it is actually establishing patient-based baselines over time and trending that. And so a respiratory rate, which has been 16 and now is 22, is different than somebody who's just 22, right? Because it's very hard for us. We can't actually do that. I don't think we could ever really do that. If you had one patient and nothing else to do, you could do that. But in the real life, nobody can actually do that for multiple data points. And so that's a good example of we would never be able to do that. And it can give you a score for everybody in the hospital. You know, just tying it together with tele-ICU, you know, what I tell people about tele-ICU is the medicine's sort of the same, but you start to think about patient care in terms of population health, which is sort of where we're going here, where you start to think about groups of patients who you're going to manage, as opposed to you're not at the bedside. You don't have to do those discussions and those other things. You can focus on the data. And so we're actually working on sort of a back office is not the right term, but something that will work in the background, a central monitoring unit to help clinicians, because you cannot do multiple things at once. You've got to have your family meeting. It is incredibly important, or you have to run a code, and there are all these other things you have to put aside, and you're never going to have enough people. So ironically, I just finished getting the data on our pilot here, which is we started looking for certain abnormalities in lactate across the health system during the day. Mm-hmm. And we have somebody like calling that. And we've already had 3 pretty good interventions because people don't repeat them. They're elevated, but they don't do anything. And it's all the things you just said. There's too many other things that we have to do. And so I think the question is, how do we get there? One is you actually have more people monitoring so that you take the load off, and or you start to develop the system so people can fly it in sort of a calm manner, which is, I think, what you're getting at. It's probably a mix, because I think there's so much data, it's going to be hard to totally clean it up. But I think, to your point, we do have good examples, like our electronic checklist, where it's pretty cleaned up. So anyway, I agree with all your points. I think it's a very fascinating future.
Yeah, it'll be interesting to see where things go.
Thanks. Other questions? Sure.
I was super intrigued by your figure 41. You might want to put it back up.
Let's see, where is that?
That's the one, the future. Yeah. So put this in context. Are we ready to go to this sort of thing? What are its limitations, its benefits? Is it being used widely? Talk to us a little bit more about it.
Yeah, I mean, I think my personal thoughts were inevitably heading towards something like this. I would say it's probably a long ways off with like the technical and ethical challenges involved in it. Although like the speed at which things like AI tools have invaded our lives is like, I think, surprised everyone, like how ubiquitous these things have become so quickly. And so your estimate is as good as mine. Who knows? Like we could be 20 years from this, or a year and a half, probably not a year and a half, but like things have been moving so rapidly in so many domains that I think it's hard to really anticipate. The major issue with coming up with something like this would probably be getting the data together and validating it. And I think as like many of the people in our section who deal with like health data have pointed out at various times, like gathering data from different institutions into one place is like a huge challenge in of itself. And like we've seen that within like one mega institution. Just getting the data is harder than you would think.
Yeah, thanks, Jake. And I think also the other theme that continues to come up is just that none of this is ready to go. Like it all requires ongoing supervision and tailoring to the systems that you're trying to apply it to. So, all right, I think we're just about at time. All right. So thanks, everybody. Thanks again, Dr.
Thanks for
Peterson,
coming.
and congratulations.